We've learned that the heart has autorhythmic fibers that enable it to beat independently, so it's not relying on nerve cells for stimulation, but its operation is governed by events that occur throughout the body. Body cells have to have a certain amount of oxygen from the blood every minute to maintain life. When cells are metabolically active, such as when we're exercising, they need even more oxygen to make more ATP. During rest periods, when our metabolism is reduced, the workload decreases, so we don't need as much oxygen, so the workload of the heart decreases also. So we start looking at cardiac output, and this is where we start trying to figure out numbers. So we got to do a little bit of math on some of these. So cardiac output is simply the volume of the blood that's ejected from the left ventricle or the right ventricle into the aorta or the pulmonary trunk each minute. So cardiac output is equal to the stroke volume, the volume of blood ejected by each ventricle during each contraction, multiplied by the heart rate, which is simply the number of times the heart beats per minute. So in a typical resting adult male, stroke volume averages about 70 mils per beat, and heart rate is about 75 beats per minute. So the average cardiac output is 70 mils per beat times 75 beats per minute gives us 5,250 mils per minute. Well, that's not very clinically useful, so let's change that to 5.2 liters per minute. So if you notice, this is about the total blood volume. Remember, we talked about total blood volume back at the beginning of our discussion on blood, and there was somewhere between 4 and 5 mils in an average, or 4 and 5 liters in an average female, and 5 to 6 liters in an average male. So 5.2 liters per minute, we're basically sending all of our blood through our pulmonary and systemic circulations every minute. There are factors, though, that can increase stroke volume or heart rate, and that is going to, of course, also increase cardiac output. During mild exercise, for example, stroke volume may increase to 100 mils per beat, and heart rate may increase to 100 beats per minute. So your cardiac output would then go all the way up to 10 liters per minute, and that's during mild exercise. So you may be wondering, well, how do we know what stroke volume is? Well, we use a couple of volumes that are pretty much standard for the average adult to figure out stroke volume. And those two volumes are end diastolic or relaxed volume, which is the amount of blood that's in the ventricle during diastole. So your end diastolic volume, full ventricle, right? Okay, it's relaxed, is about 120 mils. Your end systolic, and that should say contracting, your end systolic volume is the amount of blood that's in the ventricle after systole, okay, and that's about 70 mils. So if we started with 120, we still have 50. That means about 70 came out in that stroke volume, okay? So there are several factors that we'll look at that can affect what your stroke volume is, and these include preload, contractility, and afterload. A greater preload or stretch on cardiac muscle fibers before contraction increases their force of contraction. So you can think of preload like the stretching of a rubber band. The more you stretch that rubber band, the more forcefully it's going to snap back when you let go of one of the ends, right? So we can apply the same thing to the heart. The more the heart fills with blood during diastole, the greater the force of contraction during systole. So this relationship is known as the Frank-Starling law of the heart. The preload is proportional to the end diastolic volume, the volume that fills the ventricles, remember, at the end of diastole. So normally, the greater the EDV, end diastolic volume, the more forceful the next contraction. In other words, the more blood in that ventricle, the more that ventricle is going to be stretched, the more forceful the contraction to eject that blood. So there are two key factors that determine EDV, and that's the duration of ventricular diastole, how long the ventricle fills, and venous return, the amount of volume that's returning to the ventricles. So when heart rate increases, the duration of diastole is shorter, Less filling means a smaller end diastolic volume, and the ventricles may contract before they're fully filled. By contrast, when venous return increases, then a greater volume of blood fills into the ventricles and the end diastolic volume is increased. So more stretch leads to more blood being pushed out as those muscles contract, so the greater force of contraction. The second thing we want to look at that can affect stroke volume is contractility. So the strength of contraction at any preload is defined as contractility. So the substances that can increase contractility are what we call positive ionotropic agents. So those those that decrease contractility. Well, let's start this over. My brain and my tongue are not working together. The second factor that influences stroke volume is the contractility of the myocardial muscle cells. So that's the strength of contraction, regardless what the preload is. So if something increases contractility, we refer to those as positive ionotropic agents. Those that decrease contractility are negative ionotropic agents. So stroke volume increases when positive ionotropic substances are present, and those often promote calcium inflow during cardiac action potentials, and that's going to strengthen the force of the next contraction as more and more muscle cells are going to contract. Stimulation of the sympathetic division of the autonomic nervous system using hormones such as epinephrine and norepinephrine increase calcium levels in the interstitial fluid. A drug called digitalis, all of those have positive ionotropic effects, so they increase contractility. In contrast, though, inhibition of the sympathetic nervous system or anorexia, acidosis, some anesthetics, increased potassium levels in the interstitial fluid, all of those can have negative ionotropic effects. Calcium channel blockers are drugs that can have a negative ionotropic effect by reducing the calcium inflow. When you reduce that calcium inflow, of course, there's less calcium to bind to the troponin, and that in turn leads to less muscle contraction and decreases the strength of the heartbeat. The third factor we'll look at is afterload. So ejection of the blood from the heart begins when the pressure in the ventricles exceeds the pressure in the pulmonary trunk or in the aorta. At that point, the high pressure in the ventricles causes that blood to push the semilunar valves open. So the pressure that must be overcome before those SL valves open is the afterload. So how much pressure is in the ventricles, how much pressure is in the pulmonary trunk and the aorta, and how much pressure does it take for the ventricles to have more pressure than those vessels, where those valves will open into those vessels. So an increase in afterload causes stroke volume to decrease, so that more blood then remains in the ventricles at the end of systole. There are some conditions that can increase afterload, and those include hypertension or high blood pressure, or narrowing of those arteries, or narrowing of certain arteries, especially those closest to the heart, by atherosclerosis. And we'll talk a little bit more about that when we do coronary artery disease. So we've learned that cardiac output depends on heart rate and stroke volume. Adjustments in heart rate are important in short-term control of cardiac output and blood pressure. The SA node initiates contraction. So that, of course, is going to determine how fast the heart rate is. Tissues require different volumes of blood, though, under different conditions. So during exercise, cardiac output rises to supply those tissues with increased amount of oxygen and nutrients. So got to have more ATP, right? Stroke volume may fall if the myocardium of the ventricles is damaged, or if blood volume is reduced because we're hemorrhaging, we're bleeding. In these cases, homeostatic mechanisms maintain adequate cardiac output by increasing heart rate and contractility. There are several factors that contribute to the regulation of heart rate. But the most important are the autonomic nervous system and hormones, especially those released by the adrenal medulla, epi and norepi. So the nervous system regulation of the heart originates in the cardiovascular system that you know is in the medulla oblongata. This region of the brainstem receives input from a variety of sensory receptors, but also from higher brain centers such as the limbic system and the cerebral cortex. The cardiovascular system is then going to increase or decrease nerve impulses in both the sympathetic and parasympathetic branches of the autonomic nervous system. As physical activity begins, proprioceptors, remember those are the ones that monitor your position of your limbs and your muscles, they're going to send nerve impulses at an increased frequency to the cardiovascular center. You have chemoreceptors that are going to monitor chemical changes in the blood, and baroreceptors that monitor the stretching of some of our major arteries that can be caused by the pressure of the blood flowing through them. So all of this information is being sent into the cardiovascular system. Sympathetic neurons of cardiac axillary nerves extend out from the SA node, the AV node, and most of the myocardium. Impulses from these cardioaccelerator nerves can trigger the release of epinephrine, and this, of course, is going to increase heart rate. Also going to increase contractility because the norepinephrine enhances the free calcium, so the calcium gates are going to close to keep that calcium in the muscle cells, and this leads to greater volume of blood being released during that contraction or during systole. So as the cardiovascular system is receiving all this impulse or all this information from the cortex and the limbic system and the hypothalamus and from all these sensory receptors, then that information coming into the cardiovascular system is going to activate the cardiac accelerator nerves that go out to, as I mentioned a while ago, the SA node and the AV node and portions of the myocardium, and cause increased rate of depolarization. So that increases, of course, the heart rate. It also is going to increase the contractility of the atria and the ventricles, and that's going to increase stroke volume. Remember, we started all this because of exercise, and we needed to get more and more and more oxygen and more blood out to these tissues. So the cardiac accelerator nerves of the sympathetic nervous system respond to that stimulus by increasing heart rate and stroke volume. At the same time, the vagus nerve, which has fibers in the parasympathetic nervous system, are going to be releasing acetylcholine and trying to decrease heart rate. Remember, acetylcholine has an inhibitory effect on cardiac muscle cell. So there's this continuous shifting balance between the sympathetic and the parasympathetic stimulation of the heart. When we're resting, the parasympathetic stimulation dominates. Remember, parasympathetic is your rest and digest system. A resting heart rate, about 75 beats per minute, is lower than the autorhythmic rate the SA node fires of about 100 beats per minute. But with maximal stimulation by the parasympathetic nervous system, the heartbeat can slow to about 20 to 30 beats or even stop momentarily. So these two are constantly altering the rate of heart rate. With the sympathetic nervous system, remember, sympathetic is the accelerator, speeding things up, and the parasympathetic bringing that heart rate back down. There are also some hormones, such as epinephrine and norepinephrine from the adrenal medulla, that enhance the pumpingness or the pumping of the heart by increasing it. So these hormones affect cardiac muscle cells pretty much like the epinephrine released from the nervous system as a neurotransmitter. So they increase heart rate and contractility. Exercise, stress, excitement can all cause the adrenal medulla to release even more hormones. Also, there's thyroid hormones that enhance cardiac contractility and increase heart rate. So one sign of hyperthyroidism or too much thyroid hormone is tachycardia or elevated heart rate when resting. Ionic imbalances, too many or too few ions, can also affect heart rate, but we're going to look at that one in a few minutes, so I'll save any further comments on that until we move on into that area. Some of the other factors that can regulate heart rate include age, gender, physical fitness, and body temperature. So they primarily affect resting heart rate. A newborn baby can have a heart rate of over 120 beats per minute, but that rate gradually declines as you age. Adult females often have a slightly higher resting heart rate than adult males, although regular exercise tends to bring both sexes' resting heart rate down. A physically fit person can exhibit bradycardia, or a slow resting heart rate of under 50 beats per minute. This is a beneficial effect, though, in endurance type training, because a slow heartbeat is more efficient than one that's rapid. Increased body temperature, as if you have a fever or strenuous exercise, can cause the SA node to fire more quickly, and of course we know that is going to increase heart rate. Decreased body temperature can decrease heart rate and strength of contraction. There are certain surgical repairs that are used to repair especially heart abnormalities, that we find it helpful to slow a patient's heart rate with hypothermia or low temperature. So the body's temperature is cooled to a really low core temperature. Hypothermia slows your metabolism, and of course we know that slow metabolism is going to reduce the amount of oxygen that's needed by the tissues. So this allows the heart and the brain to withstand short periods of reduced or even interrupted blood flow during a surgical or medical procedure. When you first learned about muscle contraction, way back when you learned about skeletal muscle contraction, a lot of the same principles that were important for skeletal muscle contraction are also important for cardiac muscle contraction. So if you remember, there was a difference between intracellular and extracellular concentration of several cations, such as sodium and potassium, and that was crucial for producing action potentials in nerve fibers and muscle fibers. So it should be pretty obvious that ionic imbalances can quickly affect the pumping effectiveness of the heart, especially the concentration of potassium, calcium, and sodium, because those have a large effect on cardiac function. Elevated levels of potassium or sodium decrease heart rate and contractility. Excess sodium blocks calcium inflow during cardiac action potentials, so it decreases the force of contraction. Excess potassium blocks generation of action potentials. So a moderate increase in interstitial and, of course, intracellular as well, calcium levels are going to speed up heart rate because there's more calcium available for the binding of troponin and the leading to the muscle contraction. And, of course, that also is going to strengthen the heartbeat as well. And on this last slide of this video, even though it looks very busy, I want you to look at what we're considering here. Factors that increase cardiac output. So remember, it's important to remember that cardiac output is stroke volume times heart rate. So anything such as the nervous system, chemicals, or other factors that affect heart rate are going to affect cardiac output. Factors that increase stroke volume, such as increased preload, increased contractility, decreased afterload, are going to increase stroke volume. So all of these factors increase cardiac output. And if you had a decrease in these factors, they would in turn decrease cardiac output. So I challenge you to take a few minutes and go through this particular slide and go through each area. Increased diastolic volume stretches the heart, so the preload has been increased. Remember Frank Starling's law of the heart and the rubber band contracting, and how that stretched muscle is then going to contract more forcefully, and that will increase your stroke volume. So go through each one of these and understand how that affects cardiac output.